A dental case presentation for interdisciplinary approach. Facial and occlusal aesthetic improvements of an adult skeletal class 3 malocclusion using surgical, orthodontic, and implant treatment. The pursuit of optimal aesthetic results and functional harmony in dentistry frequently necessitates a thorough and interdisciplinary approach, particularly in cases with skeletal class 3 malocclusion. This case study outlines the transformative journey of a 25-year-old Caucasian lady who was dissatisfied with her previous oral rehabilitation after traumatic avulsion of her central incisors at the age of 12. Her subsequent implant placement and prosthesis rehabilitation were complicated by gingival recession and marginal bone loss, forcing her to seek comprehensive care. This complex clinical issue necessitated a cooperative effort between oral implantology, orthodontics, and oral and maxillofacial surgery. The treatment strategy included implant removal, orthodontic decompensation, forced eruption, orthognathic surgery, and permanent prosthetic rehabilitation. The primary goals were to improve face harmony, re-establish appropriate occlusal connections, and treat skeletal and dental deficits. Chief complaint: dissatisfaction with previous oral rehabilitation, gingival recession, and marginal bone loss following traumatic avulsion of central incisors at age 12. Diagnosis and etiology: Class 3 skeletal pattern with moderate maxillary deficiency, class A bilaterally occlusal relationship with marked compensation, end-to-end bite, and reduced overjet overbite, presence of 2 osseo-integrated implants with peri-implant tissue collapse, gingival recession, and exposed prosthetic abutments. Objective: to achieve optimal facial harmony, restore a class 2 molar relationship, and address both skeletal and dental deficiencies through a comprehensive and interdisciplinary treatment approach. The interdisciplinary treatment approach for a 25-year-old female with skeletal class 3 malocclusion involves oral implantology, orthodontics, oral and maxillofacial surgery, and prosthodontics. The procedure includes implant removal, upper arch fixed appliance, orthodontic decompensation, forced eruption, implant placement, orthognathic surgery, and prosthetic rehabilitation. Each expertise contributes significantly to addressing the various issues, with the goal of improving facial harmony, restoring occlusal relationships, and achieving optimal aesthetic outcomes. Regular follow-ups ensure that the comprehensive treatment plan is implemented successfully. Orthodontist is a dental specialist that addresses the diagnosis, prevention, management, and correction of malpositioned teeth and jaws, as well as misaligned bite patterns. Oral surgeon: they are trained to handle a wide variety of conditions and injuries that affect the head, neck, mouth, jaw, and face. Prosthodontist specializes in making dentures, crowns, bridges, and other custom-made oral appliances. Orthognathic surgeon: they specialize to correct irregularities of the jaw bones and realigns the jaws and teeth to improve the way they work. Patient: 25-year-old Caucasian woman. Chief complaint: dissatisfaction with previous oral rehabilitation, gingival recession, and marginal bone loss following traumatic avulsion of central incisors at age 12. Facial features: class 3 skeletal pattern with moderate maxillary deficiency. Intraoral findings: occlusal relationship was class I bilaterally, with an end-to-end bite and reduced overjet and overbite, 2 osseo-integrated implants in the central incisor region with a marked collapse of peri-implant tissues. Radiographs used: panoramic radiographs, periapical radiographs, lateral cephalometric radiograph. Findings: advanced vertical bone resorption in the implant region, with the first 3 threads exposed on the left implant. Left implant was in intimate contact with the left lateral incisor. Increased maxillomandibular discrepancy with marked compensation of the anterior teeth and increased labial angulation of the implants. Treatment approach: implant removal, combined orthodontic decompensation, extraction of the lateral incisors, orthognathic surgery, prosthetic rehabilitation of the maxillary central incisors, and reshaping of the adjacent teeth. Removal of the osseo-integrated implants. A clinical examination showed 2 osseo-integrated implants in the central incisor region with a marked collapse of peri-implant tissues, extensive gingival recession, absence of keratinized gingiva, and 5 mm of probing depth. Furthermore, the left implant was in intimate contact with the left lateral incisor, violating the minimum distances established to optimize aesthetics, and thus hindering the implant's maintenance. Goals: progressive mesial displacement to reduce the upper arch perimeter, to achieve class 2 relationship with the canines taking the places of the lateral incisors. Orthodontic extrusion of the lateral incisors was achieved to create a successful canine migration and appropriate prosthetic space in the superior alveolar region, allowing adequate implant installation in a 3D position. Also, this appropriately augments soft and hard tissue prior to implant placement. Orthognathic surgery, for maxillary advancement to improve occlusal and facial relationship. This advancement will create a divergence between the maxillary and mandibular occlusal planes with intrusion of the anterior segment, which will help alveolar ridge leveling. Results: successful aesthetic anterior rehabilitation, improved facial harmony, provided gingival architecture with sufficient width and thickness, improved smile aesthetics, enhanced patient comfort and satisfaction. Rehabilitating the anterior region through implant-based approaches poses a consistent challenge in dental practice. Sustaining the aesthetic and functional aspects of implants alongside natural teeth proves to be especially challenging. In such scenarios, comprehensive, interdisciplinary treatment planning becomes crucial. Addressing alveolar bone defects in the aesthetic zone, particularly vertical defects often seen in adults with periodontal tissue losses, remains a significant hurdle in implant dentistry. Complex oral rehabilitation faces inherent limitations, with notable morbidity linked to reconstructive procedures like autogenous block bone grafts and osteopromotive techniques. These interventions involve substantial surgical manipulations, including donor site surgery, multiple invasive procedures, and subsequent soft tissue enhancements. Despite satisfactory graft progress, the final volumes and aesthetic outcomes often remain unpredictable. Specifically, a vertical bone defect in this case, coupled with extensive bone resorption in neighboring teeth, pose challenges for placing bone grafts at the original cervical level. Defect etiology, including potentially limited mesial distal space for implant placement, must also be considered. In this instance, we opted for mesial orthodontic displacement and forced orthodontic eruption of the lateral incisors following implant removal to enhance both soft and hard tissue before implant placement. These procedures triggered the activation of angiogenic growth factors through mechanical stresses in the alveolar bone, fostering the development of new periodontal support, tissue gingiva, periodontal fibers, and new bone deposition via osteoblastic activity. This facilitated optimal implant placement in a suitable 3D position. The crucial condition for successful application of these procedures is ensuring the apical third of the root maintains an intact fibro apparatus.